you made a post showcasing how Zepbound, tirzepatide, was associated with a 38% reduction in combined risk of cardiovascular death or worsening heart failure. You had a separate post discussing how tirzepatide had been FDA approved to treat not only obesity and type 2 diabetes, but more recently, obstructive sleep apnea. Can you talk about the current known benefits of tirzepatide and or all GLP-1 receptor agonists, as well as what you think it will be good for in the future?
Great topic. So I, as a cardiologist, I actually prescribe a lot of GLP-1 receptor agonists. So like whether it's Ozempic or Wegovy or Zepbound or Mounjaro, because even though people think of GLP-1 receptor agonists as aesthetic weight loss, as a cardiologist, the most important thing to me is how these medications reduce cardiovascular risk factors for both the primary prevention risk factors, like, help people to lose weight and improve their blood pressure, help people to change their dietary habits and improve their cholesterol, help people improve their hemoglobin A1C, as well as secondary prevention. So there was a trial called the SELECT trial, which looked at, it studied Wegovy, and they essentially randomized individuals who have coronary artery disease with a BMI greater than 27 with known coronary artery disease to being on Wegovy versus a placebo. And they found a 20% reduction in heart attack or stroke, which was really tremendous.
Shit.
Major adverse cardiovascular events,
That's
right?
That's insane.
It's unbelievable. And then, you have, of course, Zepbound, which is incredible medication, leads to even more weight loss than Wegovy, but also is now FDA approved for obstructive sleep apnea. There are a tremendous amount of individuals who their sleep apnea goes into remission on this. I mean, the era of treating people with type 2 diabetes is completely changed, right? We actually now fall into this area where we have our little academic debates in cardiology. People that had diabetes that's now in remission, type 2 diabetes that's now in remission because of these amazing agents. The question is, well, where do they fall into the risk pool? Do they still need, that cholesterol medication if they don't have coronary artery disease? Now that their diabetes is in remission, this is a data-free zone, actually, right? And so this is a little bit more nuanced and academic of a discussion, but these medications are so effective and so incredibly powerful that, we're seeing improvement in outcomes across the board. Fatty liver disease. We're seeing improvements even with reduction in, acceleration of chronic kidney disease. So lots of different, cardiometabolic health and both, kidney and liver disease endpoints that are really valuable. And so I think that, when they became popularized, it was all viewed about aesthetics.
Yes.
And I always say to my patients, I'm like, I'm happy if you're happy, but to me, what makes me happiest is seeing, first of all, them have, better quality of life, feeling, of course, better, being more physically active, making dietary choices that are more helpful for them. But of course, their improvement in their cardiovascular risk, that's so valuable, right? Especially now in this day and age where we now know that the vast majority of dementia, including Alzheimer's dementia, is caused by the exact same risk factors that cause cardiovascular disease. And so, we talk about not just living long, but living well, right? Because if you're 95 and you have no idea what's going on, the quality of life, that may not be what you want. What if we could say, well, what about if you're in your 90s and you're living independently and you have your mental faculties and you've been listening to Jordan and doing strength training and exercise and walking, and so you have good mobility and less frailty? These are the things. I think it's not just about how long we live, but the quality of life as well. And I think that's where GLP-1s also figure into the picture. I think also another important point too is thinking about the fact that, how wrong we got it about weight and metabolism, and how for so long we have, I hate to say it, but we've just talked about diet and appetite and things in terms of willpower. And, it's such a, I look at the way we treat obesity and individuals with overweight now, in very many ways, the way we treat things like genetic dyslipidemia. I can't imagine seeing a patient with familial hypercholesterolemia and telling them to will their cholesterol down, or seeing a patient with hypothyroidism and saying, will your thyroid to work, right? Yes, it's not identical, but actually when you look at research from metabolism scientists, people like John Speakman and all these tremendous researchers, you'll see that there's quite a lot of genetic link actually. And it doesn't mean that everyone is destined to be, one weight their whole lives. But the food environment has changed, and there's so many, it's multifactorial, weight and metabolism and the way our interaction with the food environment, there's so many factors at play that it's not to say the whole world should be on a GLP-1, but it is to say that it's a tremendous advancement in science that can have a tremendous benefit for many people. And, the destigmatization of it is important as well.
So, which leads us directly into, I have to ask,
Yeah.
what did you think of my GLP-1 experiment? Which, by the way, and I know we spoke about this previously, but I was like, you're welcome to disagree with me.
Wait, so I didn't watch the whole thing.
That's fine.
I feel like I saw your post and I just said, I'm happy to hear that from you, but I didn't deep dive. So I am like a little absent sometimes from the internet. Can you just run me through? I just was excited for you. And I was like, yeah, go you. But can you run me through
Well, it's funny because I posted about it and then you left a comment with the clappy hands.
Yeah.
And someone replied underneath you. And I'll say this, the overwhelming response, Danielle,
positive?
Oh my gosh. And I think for many reasons, not least of which, I think the number of messages I've gotten, hundreds, if not into the thousands of people who are saying, I've been secretly taking it because they feel judged.
Right.
And so the number of people who are like, this is an option for me. I'm type 2 diabetic. My doctor has been saying it, but I've been resisting it, The overwhelming response has been outrageously positive. Teeny tiny small percentage of people have been really angry and posting about it on social media, and it's like, fuck you, whatever, I don't care. But you did the clappy hands and someone was like, to the effect of, oh wow, like, do you support this even though he doesn't quote unquote need it?
And I wrote, he's not my patient. I don't know whether or not he meets FDA criteria for the medication. That's none of my business.
So there were a number of reasons why I wanted to try it.
Yeah.
And I've done many, many experiments in the past. But first and foremost, I like to try things that my clients are going through. I've always found it's one thing to read about it. It's one thing to learn about it. It's another thing if I actually go through it. So that was one reason why I really wanted to try it, so I could better understand what clients are going through. The other reason that I've been overtly honest about this since I got into the industry is so I was wrestling from 8 years old to 18 years old. And I developed severe binge eating disorder, anorexia, even bulimia as a result of it. And thank God I haven't had a binge in close to 15 years now.
Wow.
But to say that like there hasn't been extra food noise and issues around food isn't accurate either. And I've been overtly honest about that.
Right.
So I spoke with my provider and I was like, this has been something I would like to try. And they also looked at my blood work and looked at everything. They're like, listen, like I have no problem having you try this on a very low dose.
Yeah.
And holy shit, it's been incredible. It's been an incredible experience. I not only has it been beneficial for me for the first time in my life, my cholesterol being in a healthier range. Not only have I I don't feel a drop in energy. Like overall, I feel great. Health markers radically improving. And it's helped me so much more as a coach to better understand not only clients who are going through it, but also then to speak with people about the potential concerns. It's been able to help me educate myself more on it, just with practical experience. So for me, it's been wonderful.
Gotcha. I mean, I think that's super interesting. So I've never been on a GLP-1, but I prescribe them quite a bit. I probably prescribe more GLP-1s than in Cardiologist in California. That being said, I think that there's clearly for you personally, like when you have that decision with your doctor, shared decision making, I think that also, I'm glad that you are destigmatizing it. But at the same time, I think that, for people to jump on and judge you, I think is not fair because that is a decision between you and your physician, right? Mm-hmm. You're not doing heroin. Okay. That's a shared decision making, whether or not, I'm not even going to ask you, it's none of my business, whether it's on label or off label, this is your business. This is a decision you make with your physician. And so I think people who jump on and judge and say things, I think that they may not understand. You could have a variety of reasons that, like you just mentioned, health-wise, that may have a benefit for being on it. That being said, when we have this discussion with patients, we were talking about the FDA-approved medications. When someone is using it, whether they're using it, on label, or off label, it's two different discussions because, of course, the when you can give a patient the information like, well, we will expect these kinds of side effects or these kinds of benefits, that's based on the clinical trials we have, which is studying a certain subset of a population. And I guess, when you have that shared decision making with the patient, so I'll tell you about a population that I often use it, quote unquote, off label in. For people who are South Asian, actually, there's a very high cardiometabolic, we know, genetically inherited risk. These people are Indian, South Asian, things like that, at a lower BMI compared to white or black people. And that BMI is 23.5. The World Health Organization considers overweight for individuals who are South Asian at 23.5. And you'll actually see any doctor who's listening or, anyone in healthcare, you'll see that these individuals, they have such a lower threshold for visceral fat where they start to develop prediabetes, dyslipidemia, all of these things. And so I have this shared decision-making, discussion with patients where we say that this is off-label use of this medication. So the risks versus benefit ratio may not directly apply to you because you have not been studied. Now, your risk of prediabetes or your risk of, your metabolic dyslipidemia, you may benefit from being on the medication, but there may be more risks depending on the individual. That's a shared decision-making process that goes into, we have to wait until that subset of a population is studied to give them that definitive benefit risk. But at the end of the day, it's a discussion with your physician. And, even though the majority of our use, of course, is on label of these medications, but there are certain scenarios, this is where guidelines come into play. Guidelines are there for a reason, they're rubric, but then remember, it's also the patient sitting in front of you, their goals, their preferences, their individual risk, their individual, history. And for some people, that's going to look different. And that's where you have to just evaluate the benefits, the risks, have that discussion, and do what works best for that individual. And I think that the issue is I think too, is that as time goes on, I think that, people really have made weight into this willpower only thing.
Yeah.
And I think that there's like a lot of, areas in the like health. I mean, I wouldn't even say the health industry. I would say just the general public that have been like, it is your fault if you struggle with appetite or weight. And, I think that is just so, it's been prevalent throughout your and I's entire lifetime until now. And I think that it's just such a nice switch to see the blame be less on just the individual. And truthfully, as you know, I'm sure when you've experienced being on it, I always say, actually, I'm working with a team on a research paper on this about the dietary interventions that can help people reduce side effects when they're on a GLP-1 receptor agonist, that it also is not a magic cure, meaning if you eat a lot of foods that are going to delay gastric emptying, if you eat foods that are really high in saturated fat, if you eat a really low fiber diet, you can have a tremendous amount of side effects on a GLP-1 receptor agonist. You can't just go on a GLP-1 and say, I am done, call it a day. Actually, you get direct feedback from your gastric tract that tells you immediately, you cannot eat this. You will get constipated. You will have intractable nausea and vomiting. And so there's this also idea that it's this cure-all, but anyone who's on it knows that's not the case. You still have to do the strength training. You still have to do your exercise, get your steps. You still have to eat a healthy diet. It's just a tool in the toolbox to help people get there in a way that they otherwise may have struggled to.
I think it's been really interesting, again, going back to behavior change and all of that, the fitness industry has come very far in understanding that guilt and shame is not usually a good strategy to get people to change. But GLP-1s brought it out of people again, where as soon as GLP-1s come into the picture, so many got on their high horse and guilt. And I'm not talking about me. I've got thick skin, whatever. But as soon as GLP-1s become a part of the discussion, there's even a woman who very kindly posted my inner circle who was just like, hey, listen, I'm considering this, but based on my BMI, my doctor isn't sure. And the vitriol and the bullying that came from this one other woman who I almost kicked out of the inner circle, I made it really clear. I was like, you are not, if this happens again, you're out. She's a coach. She's a coach who came in being like, why do you think that this would be worth it for you? Like if you're not in the BMI, which I actually want to talk to you about that. And I'm glad you brought up how different cultures have different BMIs that maybe, what do you, BMI, I feel like can be a good tool. I think we can all agree on that.
It's a tool. Yeah. It's a gross estimate, but it's not like the ultimate, best decider.
I found it interesting that generally in the fitness industry as well, we agree BMI, in the fitness industry, people hate on BMI.
Of course.
They hate on it because they have more muscle,
Right,
they're
of
often
course, right.
out of it. But then now when it's come to GLP-1s, they're all of a sudden being like, well, you're not in the BMI yet. So now they're defaulting to BMI, even though in other cases they're like, well, BMI sucks.
Yeah.
So where do you fall on that?
Yeah, so the medication has clear FDA approval. So what is an FDA approval for a medication? When we're being truly evidence-based, what does that mean? Well, it means that you can only have a true risk-benefit discussion if the patient is represented in the trial that was done, right? So if you're talking about putting someone with a BMI of 19 on a GLP-1 receptor agonist, that's obviously sounds incredibly unreasonable, right? Someone who does not need to lose weight, you're putting them on a GLP-1 receptor agonist for weight loss. If they have type 2 diabetes, that may be a different story, right? Obviously, because they're FDA approved for type 2 diabetes regardless of BMI, but that's still a discussion to be had. Now, that being said, the medications are studied and FDA approved for a BMI greater than 27 with one or more weight-related comorbidities, or a BMI greater than 30 without any comorbidities. You can have comorbidities as well, but you just need to be a greater than 30. Okay. So what does that mean? That means that these are what the clinical trials were designed around. Does it mean that it wouldn't work for other populations? No, but we just don't have that data. So with regards to quote unquote off-label use, it has to be as reasonable of a discussion of benefit versus risk as possible. We really can only endorse the on-label use of GLP-1s with regards to meeting the FDA criteria, being above that. But will I say that every single doctor? I just mentioned a population. So like, for example, South Asian individuals who the World Health Organization considers them overweight at a BMI greater than 23.5. So although they were not studied in particular in these studies at that BMI, they are considered overweight, right? And so that compared to white or black people at that same BMI.
That's super interesting.
It's super interesting. And they have a ton of higher risk with cardiometabolic disease and with prediabetes and things like that. So that's where shared decision-making comes in, right? So if I have a patient who maybe their BMI is normal and they have very elevated glycemia, they're almost at the range where they're going to reach, type 2 diabetes. They have a significant family history of type 2 diabetes. What's really interesting about type 2 diabetes is that oftentimes it does improve with weight loss. But actually, I used to think before I started medical school, type 1 diabetes is the genetic one, right? Well, yes, that can be genetically linked. But actually, the allele for genetics on type 2 diabetes is actually very strong. There's actually quite a large, genetic link for type 2 diabetes in families. So sometimes you could see individuals who are getting close to getting type 2 diabetes, but their BMI is not at 30, right? It's not even 27. So these are discussions you have to have with your physician. And as I mentioned, it's shared decision-making. It's not so black and white. But yes, the only thing that can be endorsed, of course, officially, is the, FDA-approved medication at the FDA-approved indications, BMI greater than 27, one or more weight-related comorbidities. That may expand with future studies. The FDA labeling may expand for, once randomized controlled trials are done with regards to things, like binge eating disorder. Maybe that once randomized controlled trials, if they demonstrate benefit, maybe that will be a use.
That seems to be a popular off-label use right now.
Absolutely, yes. And so there's I think that there's just, in medicine, there's always off-label use of things, right? We've historically used things off-label for a variety of indications, but it doesn't mean that it's perfect. And sometimes you have to also use caution. There can be harm, right? So it has to be a shared decision making, and to be the most evidence-based possible. Sometimes for one individual, it may have more benefits, but it may have more risks. So that's why, I do think that this is also an area with a lot of movement. I don't think the jury is out, right? There's going to be more trials, I'm sure, looking at different ranges. And like you mentioned with regards to BMI is tricky. It's not perfect, right? In an ideal world, we'd have everyone getting a DEXA scan. In what world can every person pay to go out and get a DEXA scan?
Right.
But we all know that a BMI of 27 is someone who's lifting weights does not, and that has a ton of muscle mass doesn't mean the same as someone that's not doing any exercise whatsoever. So yes, none of us are blind to think BMI is the most perfect, right? This is medicine. This is science. We know that in general, we cannot have a massive population DEXA scan because just not everyone's going to be able to afford to do that. So, it makes a difference as well. So, keeping in mind there's so much nuance and there's context. It's context dependent. And for you, whether or not you were on label or off label, if you found that your decision with your doctor was that it worked for you and the benefits outweighed any potential risks, that is something that is your decision. And I think that, I'm glad you shared it with the world so people could live through your, experience and understand it. But at the same time, your personal medical history is none of our business at the same time. And so I think it's, valuable for people to have that discussion with their doctor. There, of course, I can't say that without the caveat of saying that there's some off-labeling use that are dangerous. People with a history of anorexia that may take it too far and then worry about their bone density loss, There's something in medicine that we have to use as doctors too called common sense. And I think that also is a variable that unfortunately is sometimes in shortage.